Okay, welcome everybody to this community meeting, the third in our series of AMR community meetings. We had one in Birmingham last week, and then we had an online one on Monday, and this is the third one. So welcome everybody. I'm going to start by introducing the context of this programme, the background and our aims and some other programmes that are coming up. And then we have a series of talks from 4 non-academic stakeholders who are, well, the aim is for them to, you may not be aware of these stakeholders and their research needs as things to, when you're doing research, to, that's something to motivate you and to sort of inform your direction. And then we're going to have a series of talks from people who are already crossing disciplines in their research to give you exposure to interdisciplinary ways of working that you might not have thought of, might not have realised would be useful to your own research. We're then going to have a speed networking session to get you talking to people that you haven't spoken to before, and then we'll have lunch and you can do further networking. In the afternoon, so we had around 80 expressions of interest sent to us, which was a really great response, so thank you for that. But we need you all to be very collaborative and not quite as competitive as would usually be the case with a UKRI funding round. So we want to fund networks in as much of the AMR field as possible. And so for that, we need you to get your ideas into much broader areas. And so at the Birmingham meeting, we had around 12 ideas that were that people coalesced around. They're not the only ideas that you could coalesce around. We're very happy for you to come up with new ideas at this meeting, but we would like to move forward to a smaller number of areas, and we'll have a discussion session for that purpose after lunch. And then at the end, we're going to have pitches. So this is when you've developed these ideas in the room, and you get the opportunity to pitch that idea for a network to the rest of the room and get some instant feedback as to whether that is something that people would be interested in and find useful, that they would like to become a member of it. I'd just like at this point, so we don't sort of get, you don't keep on asking questions on it, just to clear up one thing that has perhaps been a source of confusion for some people. The networks will have, we would expect, hundreds of members each. But those hundreds of members don't all need to be involved in the application for a network when the funding opportunity opens. Indeed, one of the purposes of the network is to expand the community and bring in more members throughout the lifetime of the network. So we will expect that network proposals will have perhaps 5 or 6 PIs and co-Is, and that there will be more than that who are grouping and sort of designing the network. But it doesn't need to be hundreds of people at this stage. So I shall now talk about the context that we're in. So UKRI has identified 5 major strategic themes, major challenges for society, which needs the input of all the disciplines that UKRI supports, and they're listed on the screen there. And the one that we're specifically interested in here is the tackling infections theme. And so tackling infections is about bolstering our national defence and response capabilities by tackling infectious diseases that pose threats not just to people but to livestock and crops and our natural resources in a more integrated way. And so there's 2 particular key parts to this, which are epidemic preparedness and antimicrobial resistance. So the challenge, as we see it, is that infectious disease threats are becoming more acute, driven by diversity loss and many other global challenges like climate change, and they're compounded by endemic infectious disease threats. And the UK has made a lot of commitments at government level to G7 partners. It's talked a lot, and it's now time for UKRI to put money forward to tackle these things on behalf of the government. And we consider that at the moment the landscape across human, animal and plant health, that they're all rather siloed and they could be much more integrated and coordinated. So UKRI has spent a lot of money over the years, so we have good foundations in disciplinary strength that could help tackle AMR, but we need to capitalise on that to really tackle the problems that society needs answering. And in particular, we want to capitalise on some of the approaches and partnerships that were established during the pandemic. So tackling infections, it aims to be a sort of holistic research and innovation agenda. It's bringing together human, plant and animal health. It's bringing together the academic community, the government community, other policymakers, and industry and end users of research and civil society more broadly, and in the UK and internationally, to try and tackle this issue. So, now the money details. So each of those strategic priorities has 75 million attached to it during the current spending review period and beyond, which, because it's UKRI money, it is necessarily to support new interdisciplinary activity and also to amplify and connect existing UKRI investments that might be more monodisciplinary. In the first phase, there are two flagships for tackling infections, one on epidemic preparedness and one on AMR, which is this one, which has £10 million allocated to it over 5 years, plus any further funds that we leverage from other organisations. There's also some amplification, so leveraging core commitments, so some of our existing interdisciplinary funding schemes and adding extra money to them to inject collective value to them. And then in the second phase, so this isn't exactly determined yet, so we'll take stock and build on what we've achieved in the first phase. We'll fill some of the gaps that haven't been funded through the first phase, and also fund some focus areas which haven't yet been determined, although fungal disease across humans, animals and plants is a likely one of those foci. So, the AMR flagship. So we have two objectives. One is to connect and expand the UK AMR research communities with researchers from a broad range of disciplines, so that it's not just a biomedical issue, it is all the disciplines that are used, to transform our understanding of AMR by applying and developing a diverse range of methods, and to facilitate evidence-based decision-making by policymakers, by other end users of research in industry, in civil and broader society, through using timely, high impact and independent research. So at the moment we see the AMR community, there are parts of it where we have different disciplines working together really well, where we do have academia working well with industry, with policy, etc. But it's a small part, and most groups are working in silos. So we want to change that and get a much larger community working together on the problems that society faces. So this infographic for this AMR flagship. So in the this first part, this £3 million, we'll be funding networks that bring together academia across all academic disciplines with practice and policy and business. And they'll be able to fund very small grants to start collaborations off between different disciplines and different sectors. And the second part, the £7 million, will fund some medium-sized grants and larger grants, which will be, we'll expect the networks to shape those calls and proposals. You will have to be a member of a network to apply for one of these grants, but this is a small bar. It doesn't mean you have to be a COI or a PI at all. It means you just have to be a member of those networks, because it will be the networks that shape these proposals. And we would also hope that these networks fund into other funding opportunities, that we run our standard ones in single councils, and also other new emerging opportunities. And I'll give a few examples of ones that are on at the moment, so too early for the networks, but give an idea of the sort of thing that we do. So we have the China-UK One Health Research for Epidemic Preparedness and AMR, which closes soon. And then the India-UK partnership to address farmed animal diseases and health, which also has a strong AMR component, which closes in July. We'd hope these networks also led to more responsive mode grant applications that focused on, that were co-designed with stakeholders and involved other disciplines. And very relevant to this, we have the UKRI Cross Research Council Responsive Mode pilot scheme launching this year. And we'd hope that these networks would apply to future rounds of that scheme. So we're now going to go on to those talks by some stakeholders. I'm going to say probably no to questions at this point, because there'll be loads of opportunities over lunch and during the afternoon to ask both us questions and those who are speaking. But so without further ado, if Dominic could come up first and give his talk. Thank you.
Thank you very much. Very nice to see you all this morning. So my name's Dominic Mellor. Believe it or not, I'm actually employed by University of Glasgow, but seconded for the majority of my time to Public Health Scotland and to RHI Scotland, which essentially does what it says on the tin, in other words, antimicrobial resistance and healthcare-acquired infection. In terms of AMR, we are the subset of RHI is called SONAR, which is this One Health antimicrobial use and antimicrobial resistance team. And principally, we exist as a surveillance organization, and we bring together intelligence on AMU and AMR in humans, animals, food, and the environment in Scotland. And we work with very many partners, and most of our outputs are covered in this report. This is, I think, the fifth. And all the data that we gather from those different partners are published in this report, as well as a kind of narrative, interpretive summary. Our raison d'etre was really triggered by the first UK strategy on antimicrobial resistance. And really, we exist to deliver Scotland's commitments to the national action plans for antimicrobial resistance in the UK. In coming to talk about what we want in terms of research needs, I'm going to use a couple of slides just to talk about where I'm coming from in this. So this is our own graphic. You can, graphics on One Health are 10 a penny. Everybody has one, right? So, and all the stuff down there you don't need to read. The important thing is that I think we have observations in each of these four places, and we're trying to put them together in a report. We've got lots of observations. Observations are made there all the time. The arrows for me are the problem. I don't even agree with these arrows anymore, right? But there's nothing happening in the arrows about bringing them together very much, and that's where I'm going to focus on what I think is important. I used this slide some years ago, commenting on the 5-year strategy from 13 to 18 about what had been achieved, and if you look at the sort of pillars that sort of made up what was supposed to happen in there, we have pretty good data on antimicrobial resistance in humans, AMU in humans, AMR in animals to some extent, less so on AMU in animals, and then very little in terms of the environment, food and feed, and anything about biocides, right? And I would say one national action plan further on, some of those pillars are a bit fuller, a little bit. There's still zero integration and inference about how they interact, right? And so that is really where I'm coming from in saying what I think we need from research. And this is not just a personal Dom says this is what's important. I have discussed this with colleagues. So it's very high level elements, but for me, causation is fundamental. We have no real idea how these things interact and how, for example, antimicrobial usage in animals impacts upon antimicrobial resistance in a hospital in the middle of Edinburgh. And we've got lots of knowledge about what's happening, observations. I went to a recent AMR symposium that Food Standards Agency said, and it can tell me how much resistance there is in Campylobacter in chicken. But we don't really know why, and we don't really know why it changes or how it changes. And so knowledge why is really important. I think we've got quite a lot of knowledge about what's happening, but not really why. To me, that's fundamentally microbial ecology. And there's a big focus and fervour around pathogens and epidemic preparedness. But the notion that pathogens operate by themselves, independent of the rest of the microbiome, I think is becoming more and more difficult to believe, and we need to understand much more about interactions between things in microbiomes. And my view is my sort of naive view is that lots of things can be pathogenic in the right circumstances, partnered with the right other things that are there. And most of those things are largely ignored by conventional microbiology. So heterogeneity and resilience is really important. And again, you know, if you look at the phenotype of disease, it's something like COVID. It goes from asymptomatic infection to death. And some of that is explained by host resilience. Some of that's explained by host immunity. But what about what else is at home in the microbiome of the respiratory tract? What about what else is at home in the microbiome of the gut, and so on? So that resilience, I think, is really important. And everybody's on a kind of a treadmill about trying to stop transmission, prevent transmission. I think that's quite difficult for us to achieve as humans. And maybe it's worth throwing into the mix some idea about transmission not mattering. It doesn't matter at all if transmission occurs because we're more resilient. And I don't know what resilience means. It might mean vaccination, but it might mean having more resilient microbiomes. I'm quite interested in, you know, we're quite interested in what, you know, AMR is something that's seen as being bad, and the environment perhaps is a sort of an inert victim, and we pollute it with antimicrobial selective substances and with resistant organisms, and then they're a problem. But very little on how long do they last and how are they outcompeted, and what capacity does our systems have in sort of abating AMR. Really, I think most of our interventions about AMR at the moment in terms of stewardship and so on are empirical. And so I think there's every opportunity for them to cause all sorts of unintended consequences. So I'd like to be able to get to a point where we're understanding enough about causation to recommend interventions that don't do that. And, you know, last but by no means least, and I know this is perhaps partly technology rather than research, thinking about diagnostics and how they contribute to making sure that the antibiotics that are used optimally. I'm not going to go through the questions, particularly on the right-hand side. They're just example questions, and there are many more you could add in there. The part from the bottom one, and again, there's a lot of focus on biosecurity, including by us, or infection prevention and control, whatever you call it. Everybody sees that as a universal good. Again, it's about stopping transmission. But if it's stopping transmission of pathogens, perhaps it's also stopping transmission of many, many other organisms that are important in resilience. So that's kind of the sort of challenging, provocative thing. So that's where I'll stop. I have a very quick slide to acknowledge people who helped, and that's it. Thank you.
Thank you. Can we have Miranda next, please?
Hi, morning everybody. So my name's Miranda. I'm an animal health and welfare scientist and also a vet, and I work at the Aquaculture and Horticulture Development Board. So for those in the room who don't know who we are, we're a statutory levy board. So all of our money comes from a levy from farmers, and we cover the 4 sectors of pork, dairy, beef and lamb, and cereals and oilseeds. So as an animal health and welfare scientist, I work exclusively in the first 3 of those sectors. Our sort of main aims are that we're there to protect and promote the reputation of our agricultural industry. We provide useful tools and services to farmers, and the levy payers have to be at the heart of everything that we do. So they pay us, so we have to work for them. All of our work is done with them in mind, and everything should have a call to action or a so what message at the end of it. So we've done this piece of work. What does it mean? Why is it useful? I just thought I would briefly touch on AMR and the environment. I would echo Dominic's sentiment that these One Health diagrams are 10 a penny, they're everywhere. But contextually, we have to remember the fact that resistant bacteria are naturally found in the environment. It's not solely a man-made issue, they are there. But we can see that human activity can contribute to that as well. So an example would be oxytetracycline in pig slurry. It's a commonly used antibiotic, ends up in the slurry, used to be spread on fields as a fertiliser. Residents say, I don't like the smell of that, so we have slurry injectors to inject it into the soil, but oxytet's inactivated by UV light. So if we inject it into the soil, that UV light's taken away and we end up with active oxytet in the soil, contributes to resistance. So this is natural and it's a man-made issue. But just because we have resistant bacteria doesn't necessarily mean that it's a problem. It has the potential to be a problem, but it isn't necessarily an issue. So this 2022 study from Bath, which I've linked to, found that resistant bacteria are found in livestock, pets, and the environment, but they're not commonly transmitted to people. You're much more likely to get a resistant infection from hospital than you are from livestock. So in food-producing animals, we've seen in the last 10, 20 years that change has been largely driven by vets and farmers. So the Rumour Target Task Force targets have got vets and farmers at their heart, and they're making massive progress. So the industry's really adapted and made progress. And an example that AHDB have funded and produced is the electronic medicines book for pigs. So all pig farmers who are Red Tractor members, it's about 97% of pigs in England, have to record their medicines use in the electronic medicines book. And since it was launched in 2015, there's been a 69% reduction in antimicrobial use. And the latest UK VARS report showed that UK antibiotic sales for food-producing animals have fallen by 55% since 2014, and that includes an 83% reduction in those high-priority, critically important antimicrobials. So we're really making a big difference. And interestingly, this is a Rumour infographic, and lots of people say that antimicrobials in farm animals are a big problem, but actually livestock only uses about 25% of total antimicrobials used in the UK. So what do we want from future research? Well, we're there for farmers, and farmers need to be included from the start. Farmers and vets are the end users of antimicrobials, and meaningful change is not going to be achieved unless they are on board. We need to know what impact the research is going to have for them on the ground. How do they use antimicrobials? How are they administered? Is it blanket treatment in feed or water? Is it individual treatment orally or by injection? And for arable farmers, how do they apply their antifungals? Involving the end users right from the start will drive buy-in by giving ownership of the solution to the people who are going to be best placed to implement it. It's a carrot, not a stick approach. You know, get involved and you can come up with a solution that works for you rather than having something imposed on you from above. And any finger pointing and blame in any direction is not going to get people on board. You've got to work together. Farmers are not academics in the vast majority of cases, so we have to understand that different stakeholders are going to need different levels of messaging to get them on board, to help them to see and understand the value of making those changes and what that is going to bring for them. We need to think about what barriers and enablers to implementing research might be. So there's been a lot of research about what are the biggest barriers to implementing changes. Vets and farmers are notoriously time-poor people. I can verify that from my time in practice. Financial implication, less of a big issue. People are willing to spend the money if they understand the value behind it, but we need to persuade people that setting aside even more of your time is going to bring a return on your investment. You need to think about where the funding is going to come from, and we need to consider that all the responsibility should be shared along the food chain. So this is not just about vets or about farmers, it's about processors, it's about retailers. Everybody's got to have some say in it. And what we can do is we can facilitate every stakeholder coming to the table. So transdisciplinary should mean that everybody, right down to the farmers, has a seat at that table. We already have collaborative stakeholder groups involving farmers, academics and industry, such as the Pig Health and Welfare Council and the Ruminant Health and Welfare Group, which I'm a member of. And the other helpful thing about bringing farmers to the table is they'll tell you about what the unintended consequences might be. So you can't do this because it will mean that. AHDB's also got an extensive knowledge exchange, communications and engagement network, and that again will help us to understand those barriers and enablers to implementation, and it helps to translate these academic findings into farmer speak, basically. So how is this valuable for you on the ground? So my concluding remark would be that farmers and other end users of antimicrobials have to be at the heart of the solution, because we're not going to get anywhere without understanding how the changes are going to affect them. Thank you.
Thank you. David, yeah, thank you.
Hi everybody. So I'm going to try and do three things at once and probably do none of them well. One is to talk about CFAS, one is to talk about what we do on AMR, and the third to give us a sort of example of a PSRE, because when I'm talking there, you should be thinking about all the other PSREs involved, because they may also be able to be part of the community and be involved. So anyway, here we go. So CFAS, we are the government body from England and Wales responsible for the sustainable management of aquatic resources, providing advice to government. That's most of what we do, and we have a lot of scientists based in labs there. For the AMR, I'm going to talk more about my area, the healthy seafood part of what we do. And I'm going to introduce straight away some of the PSREs like ourselves. We have inspectorates, which are of relevance to the community, particularly our fish health inspectorate. They are responsible for making sure that we are free of important diseases that may affect our farmed fish. And we have analogous bodies, the FA in Marine Scotland, doing the same sort of job. As I'm in Scotland, I've been asked by Stephen just to try and cover aquaculture at the same time. It's an important sector, often is ignored or not necessarily given full weight in these kind of networks. And I think we think it should be. For starter, it's economically very important. 205,000 tonnes last year, we think, grown in Scotland, £500 million industry. A variety of other aquaculture operations, shellfish farming is pretty important, and also a nod to the people that own pet fish. Apparently 4 million of us do. And we all have responsibility of making sure that they are free of disease, and that has implications for AMR. What we also have, and again, other PSREs have similar, like APHA and others, a range of national reference laboratories. We help coordinate and provide, make sure that these samples are being taken properly and the right conclusions are being drawn, often method of verification and the like. Fish and mollusk and crustacean diseases, and bacterial contamination of bivalve mollusks. So I'm going to talk a little bit more about that later. But essentially, we have these networks, and we can potentially be useful for these sort of operations or initiatives. We have a lot going on. What we try to do is brigade it up under certain designations. International Centre for Aquatic Animal Health, and also one for seafood safety. Underpinning these, we have international designations from FAO and WOA, as does APHA, have similar, and other organisations. And what I'm going to talk mainly about is our reference centre for antimicrobial resistance, which is obviously direct relevance to this thing. But just showing that we have these important global networks helping provide advice and support to these important organisations. The AFAO AMR Reference Centre, that's my main job. I help lead out the CFAS part of it, but we do this in collaboration with the Animal Plant Health Agency and Veterinary Medicine Directorate, with support mainly from the Fleming funding, and we're working, and we haven't talked yet about global, but I think anything we're doing on AMR we'd love to hear the words One Health, interdisciplinary, but global perspective, and certainly this is what we're heavily involved with. And actually, this has been really exciting, really interesting work, working with low and middle income countries, helping them develop and improve their workforces and approaches for managing and better assessing AMU and AMR, particularly in the agri-environmental sectors. So something to think on if you want to work with us, because you're going to get 3 for a price of 1 if you involve us. Aquaculture, right. Farm fish, intensively reared and often. They also need antimicrobials for just the same reasons as you treat chickens or poultry or other animals, for welfare and disease management purposes, and used appropriately. We would suggest this can be sustainably done. Certainly in Northern Europe, use is relatively low, but they are used. So there is obviously yet another one of these diagrams which we put together. We'd make a play for the aquatic systems as being a potential way that the elements can be moved around. Again, international, most aquaculture production takes place in Southeast Asia. How those animals are reared and disseminated and treated, we're not often sure about whether the use of antimicrobial systems is necessarily that sustainable. Anyway, another plug for why we think we need to have a global perspective on this. And role for the research community is try and understand coming back to what Don said, these flipping arrows, what are they real strengths and importance, and of relevance to us, because we're eating this stuff on our plate. It's imported from these countries, and it's important to the UK consumer as well. Nationally, we've had a plug for VARS just now. Great report. Hopefully everyone's aware of it. We've had long-running programs in terrestrial veterinary science, producing good data, relatively good data on AMU and AMR in the other main production species. To date, not much been going on with the farm fish, and I've talked about the size of the sector. We've made a small start with the British Trout Association, starting to produce some data on some of the pathogens using initially a passive surveillance program. But yeah, we can talk about later about what we're doing. But when doing this program, I realised we need more work from the academic community to better understand if we're going to develop surveillance, how should be going out, what questions to be asked and the like. So this is an example. I think everybody's probably heard of PathSafe. I think it's been presented at all the other town halls. Quite a lot of government labs have been involved in this. And it's been really interesting. It's basically trying to get us all work together for a start. But the overall, these kind of grand aims, producing a network using the latest DNA sequencing technology to improve detection and tracking of foodborne human pathogens through the whole agri-food system. We would suggest, all involved, that under the NETS network, some of the key good things that have come out of this project would be really nice to carry them on. And I will let others talk who are more directly involved in some of these programs. But yeah, that's something we're thinking. And just as an example about how we can get involved in these sort of things is we collect samples as part of our official controls. So the expensive thing of getting the samples is done. The samples come in. We can then look for all sorts of other stuff in them. And if we're involved in these networks, we'll be able to support you with provision of really good samples that we can be used to answer particularly important research questions. Research needs. Right, what I've done is I borrowed heavily from Rick Mumford, who is the PI for PathSafe. And he said, when we're going to the networks, this is the sort of stuff we should be looking from the research community to support us. And I basically reiterate a lot of what he said. I've just tweaked it slightly. But really he should take credit for this. Ensure agri-food environment is placed front and centre of any research network initiatives to include aquatic food. That's my bit. Research that aligns to policy needs. So from where we're coming, we're talking to ministers and the others. They're looking for actually, what does this mean? How are we going to help you? We need this to support the policy here, for particularly the NAP. Can you please try and make sure, where possible, you're supporting the aspirations of the NAP? And a little example there, evidence support design, interpreted surveillance initiatives, and Dom mentioned other things that are similarly important, I think. One Health interdisciplinary approaches, echoing Dom, what does that make sure that is really done properly? And a global perspective, please. And that's one for me as well. And a little thing I popped out, some of the stuff that come out of PathSafe is some really nice integrated cross-sector platforms for sharing genomic data and resistance and AMU data are coming out of that. It'd be really nice to kind of build, grow, and make them even more useful to help ultimately guide policy and action. What can we bring? Well, as an agri and PSRE scientist, that's a useful acronym, isn't it? Access to key government departments with policy responsible AMR. So you can see a direct translation of your research into action. Pathway into it via the new NAP, government committees, etc. And you get access to existing network, inspectors to go and get your samples, reference centres to help make sure that everything's done coordinated, interpreted, and best practice passed on, and also potentially plug into some of the research programmes like PathSafe, which I know many of the UK academics have already been joining in. Thank you.
Thank you. And last, Neil, please.
Thank you very much, and I'd like to thank the organisers for the opportunity just to tell you a little bit about the work of the Medicines Healthcare Product Regulatory Agency and where it fits into this. You may or may not be aware that over the last couple of years there's been a major reorganisation within the MHRA. We are the UK medicines regulator, and the real goal about this reorganisation is A, to put the patient first, and secondly, to deliver on 3 pillars: to enable scientific innovation, to accelerate healthcare access, and to strengthen patient safety.
and the organisation the organisation of staff in the agency reflects that. So that safety and surveillance covers with a post-marketing evaluation, and healthcare quality and access about accelerating access of new medicines to patients and the public. But I'm really going to focus mostly on the science, research and innovation aspect, which of course is the work that we do to work with innovators, whether they be academics or commercial, to try and bring those products through so they get through the regulatory hurdles and become products which patients and the public can use. So within science and research and innovation, so you probably think about this organisation being primarily full of regulators, but within science, research and innovation, there are, as a directorate, there are 6 functions, and 3 of those functions at the bottom, which are circled there, are formed out of what used to be known as NIBSC, which has, and these statutory functions are retained within the MHRA. So we undertake 3 things, focusing specifically on biological medicines. Now those are things like vaccines and blood products, not the case in here, but also the diagnostics that are associated with those biological medicines. So we're official medicines control laboratory, so we do independent testing. We're also one of the major contributors to the World Health Organization's international standards development for biological medicines. So where you've got, these are controlling vaccines, the ones which are essential to make sure the quality, assure the quality. Now we prepare, curate and distribute 95% of these WHO international standards, as well as supplying secondary standards and research reagents. To undertake those activities, we need to have an active underpinning applied research that helps to understand what assures the quality of biological medicines. And when we talk about quality, that's both potency as well as safety. So how does this apply to antimicrobial resistance? This is clearly focusing in the area about patient health and bringing new medicines and new interventions to the patient and what can be done here. Within the organisation of the MHRA, they're clearly going to take 2 parts. One is at a regulatory level, because the regulators in our organisation need to ensure that medicines, diagnostics devices are safe and effective, but they want to accelerate early access of these novel interventions to the patient. And the question is, how can they do that? Well, one way, of course, is to develop guidelines that help to guide innovators and commercial manufacturers of these materials to identify what are the key features which is going to give the regulator the assurance that that is a safe medicine to release or safe device to release onto the market. Within the South Midlands laboratories, we focus primarily on the quality of biological medicines through the development of physical standards and reference materials and the development of the control tests. In order to be able to develop those standards, the right standards, or to develop the right control and test, we need underpinning research. And we need those innovators and the manufacturers to come to us to discuss what is coming down the pipeline so that we can develop these reference materials and control tests early, because ultimately that means that a biological medicine, when it comes to the regulatory hurdles, the hurdles will have been reduced because of the availability of materials and thinking, regulatory scientific thinking, that helps to provide the regulators to give them assurance in their making the right decision. And so clearly there is a mutual benefit for both the innovator and the manufacturer and the regulator to work together more closely. Clearly the academic community is a source of innovation, but medicines regulation is essential because it assures patient safety. The crucial thing about early and close interactions is it accelerates the availability of those novel interventions and innovations to reach the patient, and that's where it's going to hit home. One of the areas that we've been looking at is within our science and research innovation. We have a horizon scanning function, and we perceive areas which there's really good work where biological medicines could have an impact, which of course is development of novel bacterial vaccines, point-of-care diagnostics, which addresses the issue about choosing the right time and the right place for using antimicrobial that exist. And of course, the development of novel biological microbial treatments. We have an active research team looking to develop standards in the area of fecal microbial transplant, and they're also working with our regulatory colleagues to develop guidelines that will help people and the manufacturers to address the right questions when they want to come to seek regulatory assurance. But of course, there's the question of phage as well, and there are other questions, things that we haven't even heard of. And you could probably help to tell us that today or whenever. So that early approach is really important. So collaborative and partnership working is going to help patients and the public benefit. Thank you very much for your attention.
Thank you. We're now going to have a series of talks from some transdisciplinary researchers. So we're going to start with Till, then it will be Helen, then Alastair, and then Adrian.
The moment of truth. Here we go. That's good. Yeah, that's good. Just a moment. Voila. Okay, so good morning. My name is Till Bachmann. I'm a professor of molecular diagnostics and infection here in Edinburgh. I'm currently at the infection medicine department, but we're moving to Center for Inflammation Research. Actually, we have the launch event today, so it's a great opportunity to be here and on the other place. So I've been asked to talk about our experiences in transdisciplinary research, which we have had before in the AMR space, and I want to put this in context. And actually, it's really nice to follow up from the previous speakers, because I think where we should start with this is that we have our focal view on our very core research, what we're doing locally, but we need to look globally. We need to look One Health, and we need to look globally. And for that reason, I put this slide here, so that this is the landscape of global policy initiatives. And of course, we're driven by, as I said, what we need locally, nationally, but it's the global context we need to look at. And as such, it's really important if you start your research, and you need to think about how this fits in and how is this influenced by activities which are going globally. And I think from a One Health perspective, the activities of the quadripartite are really important. We're very well linked into this. I should mention that we have that the quadripartite is releasing their new One Health AMR strategy soon in June. There will be a launch event. There will be one from WHO, but from a One Health perspective, it's really important to look at the One Health priority research agenda. JPIMR, we're also linked in with regards to setting priorities in the One Health AMR partnership, which is going to be launched in 2025. So One Health global view. And this is where we are linked in, and where, let's say, what my background is and what I want to carry forward into the research and what drives my research. I live and breathe diagnostics, diagnostics for AMR. I think diagnostics are a really important intervention. It's a very cost-effective intervention. However, there are a lot of challenges with that. And this is what drives my research. So I was at ECMID, for example. There was the Global Leaders Group event. First time in ECMID history. If you don't know ECMID, it's 15,000, 16,000 global participation of clinical microbiologists. Of course, AMR is a big challenge or a big topic. ECMID had the pre-event on AMR, and at this pre-event there was a huge one session on diagnostics. Brilliant. Lothar Wieler, you may not know, but he was the head of the Robert Koch Institute in Germany, and he was driving all these COVID test discussions in Germany. And what he said there was really, really driving and interesting in terms of the discussion. It starts with the diagnostics, and the diagnostics produce data. Huge interest from the industry. Interest in AMR diagnostics is huge. There's a zoo of technologies out there which could be used. However, there's too little adoption and use of diagnostics. Why is that? And that's what's really driving me in terms of why do I go and do transdisciplinary research. Originally, if you want, a technology developer. I'm an innovator. I want to learn how to, or discover how to detect small amounts of a biomarker in the biological fluid and so on. However, even if you do that, it may not be adopted, and that's the problem. That down there, this is the O'Neill report. You see very little progress there. This is a gap analysis we did with WHO on diagnostics. This is a program I coordinated for JPIMR on the barriers for development adoption of diagnostics. And this is one publication of FIND, which looks at the different valleys of death for adoption of and rollout of diagnostics. And this is the Longitude Prize, which I am involved with as a judge, to find the best diagnostics. So there's a market failure. There's something wrong. People develop something and it's not adopted. And we still have an AMR problem. You know all about this, but this is what's our driver. So this brought us to this project. So the DOSA project, the Diagnostics for One Health and User-Driven Solutions, started a little bit in a situation like today. A sandpit in India, 2018, December in Delhi, and this brought together people, and we were, I think it's fair to say we were coupled together into a consortium of these people, which are on here. So part of them are, some of them are in the room today. So at the end we had a project, Edinburgh coordinating, New Delhi at IIT coordinating, and then a number of colleagues from across both countries. Now, what is actually what those people represented were these disciplines. Complete mix, and you see, just look at the colors, complete mix of disciplines. What on earth do we do from here? How do we bring these people together? And we succeeded with that. And I think we formed a really nice consortium. Consortium funding has ended. Consortium is still very engaged with each other, and we continue with the collaboration. So how did we do this? Now, we had an approach, and we had Alison Prenderville, I don't know where she is, but she guided us very well. There she is, guided us very well from a design perspective. How do you approach such a project? And so we used the famous double diamond approach, where you have first a discovery phase, define phase, you end up here at a focal point, then you develop again your interventions, and then you deliver the intervention, you test this. Of course, you can have multiple iterations. This was all foreign language to us for research scientists. This is, what on earth is she talking about here? But fantastic. And this was translated into our research program. So One Health, as the name says, so we worked in human science and in health, in the human sector, in the aquaculture for the environment, and in the dairy sector with the for the animals, obviously. What we first did was design ethnography, so going out, understanding where the needs are. What are the interactions of people there? What is the real needs? Not saying, okay, we have a technology and now you use it. No, first understand what the issue is. Understanding the networks, the stakeholders, do a baseline assessment, so sampling, sequencing and everything, understanding what AMR is there. And then, from my perspective, the green part is the interesting one. Technologies. We had all these people with fantastic technologies. They wanted to use them. They have a toolbox of technologies. We needed to focus them and concentrate on what the users and respond to what the users wanted. By doing that, we did this through development of target product profiles. So driven by the user input, driven what the need is in the settings, and then setting up these target product profiles, and then focusing on this, and then starting to develop prototypes, testing them, so developing and delivering them. And I'm just showing very briefly so how we went about. So design, ethnography, co-design, going out to speak to people, understand what they need. So this is in the human healthcare. These are people from the community. These are people in delivering the healthcare. So this is a primary healthcare center. These are people, the ASHAs, the community healthcare workers, which go on the villages and deliver healthcare there. Get their input, see what the frontline activities are, understand that. And the people here, there are technology developers here, but there's the whole bandwidth. We brought chemists out to understand what the needs are, to understand what how we could respond to that. Co-design. And then one aspect we did, user needs workshops. So we brought everybody to Edinburgh, more specifically south of Edinburgh in Peebles, and did workshops. So very well guided. Again, Alison drove us through these exercises here, facilitated interaction between the different disciplines, bringing people together to have a focus on how to develop these target product profiles in response to the users. So very, very close engagement and iterative processes. And then, of course, we also train people. So we trained, of course, we had our technologists, Yeah, so they developed technologies, but then we had people who had no idea about the technology before they engaged in the program, but we showed them how they work, what is the step to develop this, how do they function, what are the limitations, and so on. So by that, we created this iterative process, engaging everyone in the project, so the users, the different disciplines, etc., in the process to deliver the outcome. And as you can see here, this looks very simple up there. This is a paper strip, and if you look here, there's more technology here. So for example, we were not always, also where we were geared to is to have very adapted solutions, and we of course have a bandwidth of technologies which we could use there. So two outcomes in summary. What we achieved there was, so when we started this whole aspect in urinary tract infection, the community, we thought, okay, we sample in primary health care. This is where people come and deliver their urine sample when they are sick. Problem was, people don't come. So that's what we found out by the health design ethnography, going out there understanding. So people don't seek medical care because there are many barriers for them to travel, to get out of work, etc. So the idea was, that's what we developed with the users, home testing. Deliver that if they don't come to the test, bring the test to them. And now, of course, we need to understand how this would be implemented. So we developed these symptom cards up there which help people articulating that this is actually an infection, so connecting the symptoms with infection. And with that, we developed this integrated package of a test and healthcare education, awareness raising, building systems of knowledge. So people understanding what it is, what the situation is, what they can do about it. Engaging with stakeholders, so we are now at a stage where we do performance trials in the community. We engage with the local authorities, of course, throughout, with the regulatory authorities in India, and along the whole process about the implementation. Very similar, another example for aquaculture. So with aquaculture, we did exactly the same principle. So engaging with the users, co-designing solutions for that, and delivering this. So the delivery here is another test. It's again a test which by color indication shows if there is antibiotic residues in the samples. So here it's shrimp samples. And what this test does is it structures a previously unstructured stakeholder environment where the farmer here at the top has very unstructured interactions and has no agency on what happens with their samples, what happens with their information they are giving. How do they receive, for example, the approval that they can do export? That gets structured as soon as you bring in the diagnostic. So farmer involvement, stakeholder involvement. Now, how did we do this? What's the transdisciplinarity? So, as I said, fantastic team, picture from Peebles, but we have many like this. So how do we do this? What is really important? Number one is respect. Respect for everyone who's there in the network. Respect for the people on the ground out there we are engaging with. Frequent engagement. You can say today everybody wants the funding in this room. Yeah, so we all want the funding, but half year down the line when the network is happening, still engagement, still communicating. WhatsApp groups WhatsApp groups in India, of course, work very well. Co-design, co-creation of value, co-ownership, co-authorship, for example, having people on the paper. That's difficult. And that's exactly the difficulty we see here. Where do we publish publications? Social science publications and health publications. Different world, different impact factors, different review process, and so on. That's really challenging. Co-leadership, we had co-leadership so from India and from the UK, but of course the different domains needed to be involved. The recognition of contribution is really important. You can't just go, take a sample and never come back. You bring people in and they're involved. And what is it, what people drive? Why are people engaging with this? Of course, it's a fantastic program, but it's the curiosity of uncertainty. If I start engaging with a social scientist, let's say I'm a biosensor person, I don't know about social science at all. I am curious, I embrace uncertainty. Maybe it's get difficult, there are difficult situations, but we overcome them and we gain importance through that, or gain impact through this. And of course the shared values are really important. It's not always easy. Now, of course, time zone differences, language issues, culture issues all need to be addressed, but they are addressed through engagement and respect. Now, with that, this is from the DOSA project. So this This principle we are using, of course, also in Edinburgh. We have the Edinburgh AMR Forum. We started this some years ago, actually before DOSA, but with the same idea, bringing together the different disciplines to work together on it. And that's with the same principles and with the same challenges, of course, because people have different motivations. But the uncertainty people embrace and the benefit they get from this are actually quite positive. Now, and of course, we started with this, or we do similar things like now, of course, we bring people together, talk about and co-design approaches, for example, for this call. So this is just recently when we met. And in this room, we had just Dominic organized a fantastic meeting the last 3 days before here, speaking about livestock and AMR. So this is all embedded in this community, benefiting from this transdisciplinary background. Thank you very much.
Thank you. We'll have Helen next. No, I don't.
We can plug mine in if that's easier.
Oh, can you plug it in?
Well, I don't know.
Can't
I haven't
plug
tried it,
Hang on.
but I've got it up, so... is it just this one? Excellent. Hello everybody, thank you very much for inviting me to speak today, and I hope and think that what I'm going to be talking about is quite complementary to Till. I'm just starting with a bit of a preamble for those of you who aren't social scientists. I myself am an anthropologist, but I think much of what I want to say is more general to some of the social sciences. So just to kind of highlight the complexity of AMR as a problem and the way in which human action really is fundamental to thinking about the evolution, transmission and spread of AMR. It is obviously a natural biological process. It could be going on in the environment completely independently, but much of what is happening even at an evolution level for microbes is a result of anthropogenic processes. So I think the drivers are very important to understand from a social point of view, as well as, did it on its own. Sorry. And the interventions that we might come up with equally, whatever those might be, whether they're diagnostics, as Till was talking about, or infection prevention, control, better sanitation, whatever, having a biosecurity approach to the aquatic environment rather than dumping antibiotics into the ponds, depends on these kinds of social determinants. What's also important in terms of thinking about working in a transdisciplinary way is that how we frame the problem in the first place also affects where we're going to end up in terms of our solutions. And what we want to invest in and how we do that research. So I feel very strongly that social science is needed kind of throughout. Just in case, by way of background, in terms of wondering why an anthropologist is speaking to you, I actually engaged in some activities linked to this getting on for 8 years ago now, when I worked for a couple of years as the AMR champion for the ESRC, which precisely involved trying to galvanize the social science community to get involved with cross-disciplinary AMR research. And that was fantastically interesting and exciting, and I learned a huge amount from it. And I then got involved progressively in, although I'd been somewhat involved slightly in relation to sexual health and STIs and gonococcal resistance previously, I've subsequently been involved in a whole range of increasingly complex, increasingly One Health-oriented projects. and I also with Till on the Nestor Longitude Prize, among other things. So without more ado, I just want to run through in a similar way actually the first of those projects that I've just listed, which I led for 3 years. It was a Newton Fund project, collaboratively, bilaterally funded between the UK and China. As you can see, it was focusing on determinants of antibiotic consumption and prescribing in rural China. And we had a range of objectives and research questions, but the salient thing to note here, I guess, in terms of transdisciplinary working, is that these span social science, issues around treatment-seeking practices and understanding the social, cultural, economic and health system drivers of antibiotic use, microbiology to try to see whether we could actually characterize prevalence of AMR in community settings in rural areas. So this is outside the large urban hospital places where the national surveillance goes on. And thirdly, epidemiologically, seeing whether we could use secondary data from patient records as a sort of tool for surveillance in the future. The way in which we tried to link these three objectives was through actually what is, by background, an anthropological design. I don't want to go into it at any length here, but as you can see, each element is sort of triangulated between patient experience, i.e. what people come and report when they turn up at a clinic or indeed a medicine shop asking for medicine, what the doctor or other healthcare provider then tells them is wrong with them or doesn't even tell them but just writes a prescription on an assumption that there's a certain diagnosis. And then thirdly, what comes up when you do lab culture, whether there are clinical isolates, whether there is indeed a pathogen, and whether those pathogens are resistant. And that is actually, I won't go through, these are the sort of complicating factors which may make that relationship not straightforward. But it's actually based, as you can see at the top here, on a medical anthropological conceptual framework which makes distinctions between biological disease, subjectively experienced illness, and socially recognized sickness. So that's where kind of my anthropology kind of fed into a very interdisciplinary research approach. And I have to put my hand up and confess, I didn't tell my collaborators that's why I conceived of it like that at the time. It just sort of emerged out of our discussions. However, how do you do it? It's not necessarily straightforward. And as Till said, you need to kind of be very open and talk to each other all the time about what you're trying to get at. I've just put here one methodological issue, which was how do we decide on who to recruit in terms of our patients? So in the original proposal, we just said, I mean, I'm a social scientist, I'm not a doctor, I just put patients with common respiratory tract infections, because we know that is what, in the UK, 70% of people going to GP practices and getting prescribed antibiotics have common respiratory tract infections, kids with coughs and sore throats and that sort of thing. So it's an important area. So our microbiology colleagues go, oh, we need to look at exacerbated COPD and UTIs. Digging into that, though, we realised that, well, those things are what you should be prescribing antibiotics for. The key point here is that from a social science point of view, it's at least as useful anthropologically, if not more useful, to have patients who don't turn out to have a bacterium causing their illness, but who are prescribed antibiotics, than those who do have such a bacterium and therefore are being appropriately prescribed antibiotics. And that actually tells us a lot more about what is going on in the clinic and the prior assumptions. So we kind of need to dig into those sorts of things. And as I've suggested, conversely, from a microbiological point of view, if you can only do 1,500 tests within your budget, the broader the spectrum is for diagnostic, for inclusion, the less likely you are to end up with the number of isolates that you're going to be able to culture. So you want to target as narrowly as possible. So you've got conflicting aims which have to be kind of worked through in developing your design. So anyway, we ended up doing a shed load of work, which was great, and let us do some fun stuff, particularly by dint of doing quite long-term observations in the clinics, as well as in-depth interviews, which then allowed us to do things like compare what people said when they left the clinic in terms of whether they'd been prescribed an antibiotic with what our researchers sitting in the clinic saw happening. And these are all patients who had been prescribed antibiotics. These are all people who turned up at medicine shops who had been sold antibiotics. And you can see there's an interesting discrepancy going on. It also allowed us to look at why those discrepancies were occurring through doing in-depth interviews with a whole range of different providers. And, for example, to look at this issue, very interesting issue about there being a difference between what you saw in the electronic records and what we knew to have occurred in terms of symptomatology, diagnosis, and prescribing in the actual clinics. So, and why is this important? Well, of course, as we know, my colleagues wanted to do this record review study simply to get a measure of the extent to which there was incomplete data and missing records, from which they were planning to then download county-level records, ideally provincial-level records, to be able to do an analysis of all that secondary data and look at trends in antibiotic use over time. But because we'd done observations in the clinic, we were able to get a much more accurate picture and demonstrate that that kind of information actually would have been systematically biased and probably misleading. What I was also invited to say something about by Stephen, though, is why is this interesting to me? Why would I encourage a social scientist or another anthropologist to want to work in this area? I would say it is the most fascinating and complex topic I've ever worked on, which is why I've ended up in the AMR kind of nerdy silo, I guess. But in terms of that aspect about surveillance and medical records, it's very interesting to me as a social scientist because policies are implemented to create changes in the real world. How do we then know whether those policies are working? We do things, certainly in China, by doing things like trend analysis of antibiotic prescribing over time. And we go, oh, yes, it's declining over the last 5 years, so this policy is working. But what we know from the kind of work that we did there leads us to understand that there is a kind of looping effect going on, whereby the changes in regulation can affect what gets into the records, and then the records are used to supposedly monitor how well the regulation is working. And this is sociologically, anthropologically really interesting. Helped me to get a Wellcome Trust Seed Award to look at that further. Another area in terms of my own background, I'm actually an Indianist, and I've long been interested in issues around language and meaning. This work, even though I wasn't able to do my own ethnographic field work, I'm not a Mandarin speaker. I was fortunate enough to have a senior research associate who was, and it enabled us to dig into these very interesting issues about the way in which concept of antibiotic has become attached within a local language and local conceptual understanding to a concept which pre-existed the introduction of Western medicine relating to a notion of inflammation. And that is a really important driver of why people want to have antibiotics when they experience something that they would categorize as inflammation. And so that's just an example of that. Similar sorts of issues around looking at the economic drivers and the way in which we might understand it from an anthropological point of view. That was the first foray it was a fantastic collaboration with Anhui Medical University and helped us then to subsequently develop and get funded this UK-China AMR Partnerships Hub, which was massively expanded with 3 universities in China and 5 in the UK, including Public Health England, now UKHSA, and which was much more One Health oriented, where we had a sort of set of different work packages, developing that primary care study of drivers that we'd done into an intervention and a trial, and then secondly looking at environmental and livestock, and then bringing that all together to do socioeconomic evaluation and modelling of the burden of AMR. And finally, just to broaden this example, I'm currently involved as a co-I in a very different study called ResFarm, which is looking primarily at environmental AMR, in particular looking at the impact of the pharmaceutical industry on the evolution of antimicrobial resistance, antibiotic residues in the environment and its effect on the health of local communities. So again, this is something where we need to have social science involved, because people are not only just being exposed indirectly if they are, for example, drinking water which is contaminated with antibiotic residues, or eating food which has been grown on soil which is already, has potentially antimicrobial resistance genes in, but we also need to kind of take out, as it were, the direct exposures that they may also be having through antibiotic use. So these are the objectives of the social science component. The rest of it is a huge water and sediment sampling study in 2 sites, one where there's a lot of pharma industry and one where there is none at all, so that we have a comparison in Himachal Pradesh. And we're doing a whole range of different kinds of studies, including ethnographic work, to document sources of potential exposure among different communities living in the 2 areas. So I'm hoping that we've still got another year to go on this one, that this will help to inform not only understandings from a microbiological and environmental science point of view of what is actually going on in terms of environmental AMR, relating to some of the questions that you were putting at the beginning, but also that it may potentially help us to think about possible solutions and implications for policy and practice, the ways in which we might mitigate risk of exposure if indeed we do, and we've got some early evidence on this, show that there is a lot more in the way of antimicrobial resistance genes floating around in that pharma industry environment than there is in the pristine environment up in the hills of Himachal Pradesh. So just to conclude, and I would certainly endorse all of Till's previous comments about other things that one needs to think about. My own thoughts are that it's really important to articulate but also reflect on your own disciplinary methodological assumptions. It's certainly been incredibly helpful for me. As you will see, I've gone very far from being an ethnographic purist, very happy to get involved in informing quantitative work and working with other people, and they can indeed give me insights, further insights into my own preoccupations, theoretical and disciplinary preoccupations. But you also need to be ready and open to interrogate the epistemological assumptions, the basis of other people's assumptions. You need to ask those questions about why and embrace other people's methodologies, but ask kind of, why are they making this assumption? Is that actually correct? Maybe I've got a different view of that, and perhaps that is as valid. So it's kind of about digging underneath people's expertise, really. Ask whether and how other people's disciplinary approaches may help shape and answer your own questions. And last but not least, just because it's, I know, a personal bugbear, not just of me, but of most other social scientists I work with, apart from social psychologists who actually do this, don't assume we only deal with something called behavioural change. And I hope that I've illustrated that for you. Thank you.
Thank you. We're going to just swap round. Adrian is going to go next.
Good. So that's working. Well, it's a pleasure to be here in Edinburgh. We were given a tough brief, the four of us, just describe our own research area and discipline, and then how we have facilitated interdisciplinary and transdisciplinary research in AMR. So first of all, we've got to say, what we do. And I think the first problem that any of us face in transdisciplinary research is communication. It's communicating the jargon and the assumptions and the theoretical frameworks that we have and the methods from one discipline to another. And the guiding principle of the Bridging the Gaps project that we had, that I'll talk about at the end, was that there are no stupid questions. You have this. I thought Tel put this very nicely. You have to have an atmosphere of respect, of mutual understanding, and I've had to learn an awful lot from many different areas to be able to understand what they were talking about and why it was relevant. So my own research, why the hell am I here? Well, I work on the other end of the spectrum in terms of length scale. So I'm looking at the molecular basis of drug resistance, including antibiotic resistance. There's been another pandemic recently that's had some attention, and methods have been put to the test in the COVID pandemic as to whether we can do something useful. So what I'm doing is I'm using computation to understand the molecular basis of disease and drug resistance, and that's now widespread and has been used quite. These techniques are now used and have shown their worth in the COVID pandemic. So that's been in areas like drug design, increasingly in the design of vaccines, so using simulations to design and test vaccine candidates. That's something we're working on in Bristol. To understand the structure of viruses, so the famous spike protein. So the dark blue here is the glycosylation of the spike protein, and what the simulations did here is reveal how that glycosylation shields the spike from the immune system, and understanding how mutations change that. So we've done various work on COVID targets, identifying druggable sites in the spike protein, designing and testing inhibitors of the main protease, and recently looking at mechanisms of Paxlovid resistance. This is simulations on all sorts of scales, and this is the largest scale that I can get at in my simulations. So these are simulations of the delta virion of SARS-CoV-2 in a respiratory aerosol. So these long snaky things are mucins. So this is atomically detailed. This is a 1 billion atom model, and that's about the biggest that we can look at. That's using exascale resources, such that some of the biggest computers are usable by academics in the world. And this is a collaboration. It's collaboration between different sorts of modelers and simulators, the US, and in industry. So that's the sort of large scale of what we can do. Other things that the COVID pandemic have highlighted, and this is common and recognized across many disciplines, is the need to share data and share models, and to do that reliably and rapidly and in a properly curated way. And I think there's great willingness across disciplines to share data, we had hundreds of groups signed up to this initiative to share their models very early in the pandemic. What we needed was tools to do that, and so a US institute, MOLSI, and an EU one, BioExcel, came together to make a repository to house this data and put the effort in to do it. We really need that for other sorts of problems too. And also the pandemic's highlighted new ways to collaborate, and one way we've done that is through the use of virtual reality. And so when we were all sent home in lockdown and we couldn't do very much, and we were designing these inhibitors of the main protease, one way we did this was to work together in VR. So this is a view of one of my students, Helen, and you're seeing the headset there of the other, Becca. They're working together on a molecular problem here of how does a peptide substrate get into the main protease. But what was important here is that they were both in their flats at home, but they were working together in the same virtual space. Now, this is a molecular design problem, but obviously, co-design, this can be done virtually, and there are interactive VR tools to do that, and I think that provides a very exciting frontier. And I think we'll see something in terms of more sort of macroscopic uses in a second. These techniques, why are they useful in AMR? Well, we work on establishing, understanding the chemical mechanisms of drug resistance. So this is the breakdown of benzyl penicillin by a beta-lactamase, 10-1 beta-lactamase. We work on design of specifically inhibitors. So, everyone I think is familiar with coamoxiclav. So how you can re-establish the use of an antibiotic by co-prescribing an inhibitor to combat that resistance. And we're looking at, for example, the fitness cost. So we're looking at transmissible colistin resistance. And the global dimension of AMR is all important, and that's come up in several talks, and Helen Till mentioned this. So this is the notorious MCR1, which was first characterized in China, and with work in China, this structure of the protein was established by my colleague Jim Spencer, and we're looking at how it works mechanistically, and also what price the bacterium pays for this resistance. So my experience of running a interdisciplinary or transdisciplinary project comes specifically from this project Bristol Bridge, which we had. It was a very nice initiative from EPSRC, not a lot of money, but specifically designed to bring physical scientists into the AMR arena. And the main problem there was convincing physical scientists that they had something to offer. Why is my research relevant to do this? So we set up, so the design of the project was all important. So we had 3 different strands, one on discovery of new antimicrobials, on assays and diagnostics, one on materials and delivery, and one on surveillance and intervention. And each of those strands was co-led by an AMR specialist, life scientist or biomedical scientist, and a physical engineering or mathematical scientist. And we had world cafes where we brought people together and tried to explain in very simple terms what an AMR challenge was. So dealing with the infections in cows' hooves, how do you apply something effectively to that doesn't wash into the soil? We were able to leverage some additional funding. We got involved even in I never thought I would be involved in creating a comic, but we consulted on a comic. So, how do we influence public understanding? And we trained physical scientists in microbiology. And that has equipped several early career researchers with skills which they're now using. So there are a couple of people in Bristol and elsewhere who are continuing research programs, having begun as an engineer or a physical scientist in AMR applications using those microbiology skills. So the sort of things we did, we were supporting projects in new materials, new diagnostics, using AFM or rapid point-of-care tests. But the crucial thing here is we had small amounts of money. So we had we funded, I think, 17 pump priming projects, and we judged those as a group internally, and we were able to act really rapidly. And crucially, every project had to involve, you know, physical or engineer or mathematical scientist and a biomedical scientist, and it had to be blue skies. There had to be some translational possibility. And you know, not everything pays off, but we were able to fund research which could not have been funded in other ways. But a lot of this is built around the people. You can have a great idea, but if you don't have a person within the institution or nearby to do the work, it's very difficult to do it. I think it was, you know, in terms of value for money for EPSRC, so it cost them less than £600,000 and funded 17 projects. So that was, some of that was leverage, so we got industrial support, we got support from the Global Challenges Fund and so on. We did outreach, we went to schools, we trained 30 postdocs. You know, they're not 3-year postdocs, but 30 postdocs benefited from training, postdocs and PhDs. We demonstrated to hundreds of school children, and we contributed to the development of this Bristol AMR network, and more broadly to the GW4 AMR network, which Helen is now involved in leading. We reached policy, we're reaching out to policy makers and influencers, and this is how Helen and I first came into contact with each other, because when she was AMR champion, and we had events with social scientists, with anthropologists, and really crucially, I think there was because it was the days of the Global Challenges Research Fund, we were able to access some of that institutionally and more broadly, and engage with researchers from other countries and learn about problems, you know, like in Thailand, people injecting fruit trees with amoxicillin, literally, you know, which Thai researchers were horrified about. But the cultural dimensions, and co-design of projects, and identifying real solutions, not just what you think might be a solution, is really a global problem. So I think that's all I need to say, and I'll hand over now to Alastair.
Thank you.
Lovely. Thank you. Thank you very much. Thanks for the kind invite. I'm Alastair Macdonald. I'm Senior Researcher in the School of Design at Glasgow School of Art, an art school, speaking at this kind of forum. I've got a bit of resonance with the previous 3 speakers, and I'm a bit jealous of Adrian because he got his videos to work, and unfortunately I couldn't get them to work on the system here. I don't think we can tackle complex problems like healthcare acquired infections or AMR without taking a more holistic view that includes people as actors in the whole kind of mix, and you know what they do, who are they, how can their behaviours be modified. So with our very close working with people, what might the arts and design in particular have to offer the AMR community? So what I'd like to do is to take you on a bit of a journey through 4 studies at quite small scale, all funded by the HRC. We'd had some previous success in visualizing what was invisible in adults, older adult data, and also in stroke rehab. So we knew that our work in visual tools, visual methods could have some impact in healthcare. So we were asking the question, can we, in AMR with pathogens being invisible, could we make those visible? Could that improve understanding of issues, change in perception of risk, and change an intent to change behaviour? So I'm going to show you how far we've got through this particular journey, and bringing in on the other side nursing and sciences of various sorts. So this is where the little videos would have been really good, but the first project was very speculative, and we were kind of asking what if we had pathogen goggles and you could switch those on and look through the room. what would you see? So what would the nurse see? What would the nurse's preoccupation be with? What would the cleaner's preoccupation with? So if you've got the cleaner in this ecosystem, what might be the preoccupied with? What might be their perceptions of where the issues are? And if you switch the goggles onto the nurse, what would their preoccupation and perception of risk be in that particular environment? So we had some very good responses from that. Another aspect of this hypothetical pathogen goggles was, if you had augmented reality that gave you additional information as you looked at this around the room, might that make you behave differently? So we had some quite good success, quite good feedback from that initial study. So we then moved into a second study where we said, could we, with quite a modest training package of about half an hour, change people's perception of risk? And here we developed a tablet-based app looking at particular pathogens, C. diff, norovirus, and MRSA. And we looked at things like their reservoirs, the pathways, transmission pathways, and what effects IPC mitigations might have on things. So it's a very co-design process. We built a tablet-based training tool, and we were in design. We build to think. We like to make things and get some feedback immediately from people to kind of help us on our way. So we had some very good responses to that, and improved awareness and understanding of risk, and being able to kind of see the issue contextualized in the virtual ward, making them feel more kind of real about the situation. So that proof of concept, and that study was assisted with Gamma Healthcare, probably better known for Clinell wipes. So we moved on to a vet study, so the University of Surrey, and with a large referral practice. And what we did was we refined the work in the previous study into a training app for vets, vet staff at all grades. And I think the same issue as the previous study. The training app was for not only the clinical staff, for the nursing staff, but also for the domestic staff, because they're part of that ecosystem, and the training app would have to be appropriate for them. So the training app for the vets situation was built around quite a carefully, tightly structured narrative, our training tool, where the central question was what can be done to get the dog Marley into theatre with as little contamination as possible, both on him and left in the preparation room. So this was built around a particular surgical procedure, and the training, the 3D model which we built was based around hard evidence, so 15 hours worth of video data which we analysed for risky behaviours, and compressed this into a series of 7 different scenarios within that surgical procedure. So it was based around a kind of three-layer model. So we invited the trainees to look at this and say, can you spot the potential sources of infection, the risky behaviours and routes of transmission within this particular model? And then we revealed this, so asking them how well did they do and what did you miss? And a couple of little, this looks great on video, but it just gives you an example. If you look at the hand of the woman on the left-hand side as she touches her specs and so on. So we could actually demonstrate incidents of risk within this video, which were invisible initially, and then we kind of revealed them. And then we had the third layer, which is about the infection prevention control measures that might mitigate risk. And again, we would ask, what kind of IPC measures could you introduce, and what kind of effects would they have on the outcome to improve outcomes? So again, we did a small pilot with 50 vets, and we found that we had quite a large shift in intention to change their behaviour. And the prototype that we developed in that study was used in the undergrad school at the University of Surrey's vet school. So about 400 students had experienced this as part of their infection control training. So we moved into develop that as a beta version, standalone app for tablet and mobile, and a WebGL resource for virtual learning environments and for massive open online courses. So that's been taken into a PhD. So we want to actually see in the trial in the PhD, will this actually change behaviour? If so, for how long? Will there need to be backup? And does this result in a reduction in infections and in the use of antibiotics? So again, that's supported by industry. So just a few short slides on co-design, very much aligns with Till's presentation. It's really important. This is inclusive and iterative from the outset. So we had about 150 participants helping us stage by stage through the mock-ups and the prototypes, including nurses, junior doctors, and domestic cleaners and medical students, iteratively evaluating this at each stage. We're very mixed methods, so it might embrace anything from video evidence, pathogenic data, behavioral data, to paper-based prototypes, digital tools, acting, role-playing, and so on. Now, as a designer in this kind of work, I don't say, I'm going to design this, I'm going to ask you what you think of it. The question is, how do you think this should be designed? So the tools for that kind of collaboration are really important. So we took some stills from the 3D model, and we asked, how should we show the transmission of infection in these particular situations? So this allowed, say, the veterinary professor in this particular case to articulate that. So if you have a big group of people, you get a lot of data like that. And similarly, asking what do you think the interface for this thing should look like? So this is a veterinary nurse, and that's her sketches on the left-hand side and translated into something a bit clearer on the right-hand side. So, how are we doing? Well, I think we're kind of working our way down this particular journey. The PhD study, which is current, will give us some more data. We have got some other ideas for livestock applications, and I'm speaking to people in NHS Scotland about bringing this back into human health. So it's truly transdisciplinary, if you can see all the different disciplines that be involved along the way. I would like to mention two particular individuals, Colin McDuff, recently of the Robert Gordon's Institute in Aberdeen, and Mark Chambers at University of Surrey Vet School, who've accompanied me on this and supported this journey. So, thank you very much indeed.
Thank you. We're now going to go on to the speed networking session. Before we do, I thought it would just be important, you might well start to have questions to ask us, so just make sure you know who all the team here are. You should be able to ask the same questions to